Great. Welcome, everyone. Good evening. Welcome to the Foundation's Journal's Best of webinar featuring articles from both our Inflammatory Bowel Diseases Journal as well as Crohn's and Colitis 360. Tonight, we'll be going through two articles from each journal that were awarded Best of 2021 awards. We can begin the slideshow. Great, thank you. So we'll start with the best clinical and basic science articles from Inflammatory Bowel Diseases. Inflammatory Bowel Diseases is our highly acclaimed publication featuring original peer-reviewed articles on cutting-edge topics in both print and online. We'll also be featuring articles from Crohn's and Colitis 360, which is the Foundation's online open access journal featuring the latest content on comprehensive care for IBD patients. You can go to the next slide. So I'm excited to introduce our editor-in-chief for inflammatory bowel disease, Fabio Cominelli from Case Western University, and our deputy editor, Sonia Friedman from Harvard Medical School. And they'll both be introducing each of our inflammatory bowel disease article winners. And for Crohn's and Colitis 360, our editor-in-chief is Miguel Reguero from Cleveland Clinic. Unfortunately, he's unable to join us tonight. And our deputy editor, who I'm excited to share, will be here tonight to interview both of our authors from Crohn's and Colitis 360 is Alan Moss from Boston Medical Center. So you can go to the next slide. Here are the four articles we'll be featuring tonight, and the authors from each of these articles are joining us. As a background on our Best of awards, each year published authors in inflammatory bowel disease are considered for this annual prize in both basic science and clinical research. And for our inaugural year this year, we have also selected two articles of excellence from Crohn's and Colitis 360. For both journals, we use article citations, usage, and altmetric scores to select the top 10 articles to be considered for the awards. Those articles are then voted on by each of the journal's associate editors for the respective journals, and two winners are selected. For the IBD journal, we have one basic science and one clinical research award that is offered, and for Crohn's and Colitis 360, it's the top two articles. And awards are meant to reward and recognize the team of authors, so all of the co-authors that you see on here did contribute to the winning paper. And with that, I will pass it over to Dr. Friedman, who will introduce our first speaker.
Orna, thanks very much. It's my pleasure to introduce Dr. Kristen Burke, who's a gastroenterologist and IBD specialist at Mass General Hospital in Boston, and she'll be presenting her paper entitled Immunosuppressive Therapy and Risk of COVID-19 Infection in Patients with Inflammatory Bowel Diseases.
Thank you very much. On behalf of all of my co-authors, thank you to the editors for this award. So to set the stage for when we performed this award, so we undertook this multi-center study shortly after the emergence of the COVID pandemic. And at that time, risk factors for contracting the disease and developing severe disease were really poorly understood. And if you guys all recall, kind of at this time, only patients who met criteria for significant symptoms were referred for COVID-19 testing. There was no asymptomatic screening. And anecdotally, this is a time that a lot of my IBD patients were still kind of in hiding from the virus because we didn't know a lot about its role in immunosuppression. As background to this, early data from the first wave of the infection did suggest that individuals who are immunosuppressed were at increased risk for severe disease. So we leveraged a large multi-institutional cohort of patients with IBD in Massachusetts to assess the incidence of documented COVID-19 in patients on aminosalicylates, anti-TNFs, and non-anti-TNF biologics, and to define the impact of immunosuppression, both monotherapy and combination therapy, and comorbidities on disease outcomes. We included patients receiving care within the Mass General Brigham and Women's Healthcare system. This is a large system comprising 2 tertiary care referral hospitals, and then also multiple other smaller hospitals. And we used a research patient data repository that warehouses information obtained from any healthcare encounter within our health system. We included adults over 18 years of age with at least 1 ICD code for Crohn's disease or ulcerative colitis. And to accurately define our denominator as patients actively receiving care for IBD, we also required at least 1 prescription for an IBD medication. Our primary study outcome was development of COVID-19, defined as a positive PCR test for COVID on nasopharyngeal swab, and an attending gastroenterologist reviewed and confirmed each case. For each case, we extracted information on whether the infection was severe, which we defined as COVID-19 resulting in hospitalization, ICU stay, or death. We extracted from the medical for the medical record covariates including age, sex, race, type of IBD, other comorbidities including asthma, diabetes, hypertension, and obesity, and then IBD medication exposures at the time of diagnosis, including corticosteroids. We performed multivariable logistic regression to identify independent predictors of COVID-19 infection amongst patients with IBD. And to ensure that the findings were not due to selection bias and referral for testing, we performed a sensitivity analysis comparing patients with positive COVID tests to those who were tested but tested negative. We then performed an analysis restricted to cases to identify predictors of severe disease. Our study included 5,302 patients with inflammatory bowel disease. The mean age in our cohort was 46.5 years, and the most common immunosuppressive regimen was anti-TNF monotherapy in 29.7% of the cohort. 20% of the cohort had received a prescription for prednisone within the study period. Turning your attention to our table 1, you'll see that 39 patients in our cohort were COVID positive, which is an incident rate of 0.7% in the study population, which was actually on par with the rate of COVID-19 in the population at that time. Comparing those that were COVID positive to COVID negative, people that were COVID positive were more likely to be obese. In our primary analysis, we found no association between immunosuppression and rate of COVID-19 infection. If you turn your attention to our figure 1, this looks at risk of COVID-19 infection by medication category, and you can see that it's roughly similar for aminosalicylates versus immunomodulators, anti-TNFs, vedolizumab, and combination therapy. Comparing individuals on no immunosuppression versus those on immunosuppression, or those not on steroids to those on steroids, there was no significant difference in rating of COVID-19 infection. Our multivariable adjusted odds ratio for any immunosuppressive on risk of COVID was 1.73 with a 95% confidence interval of 0.82 to 3.63. I would say that these findings were consistent on our sensitivity analysis. We also found that immunosuppression was not associated with risk of severe COVID-19 amongst positive cases. Of our 32 patients with, of our 39 patients with COVID, 7 had severe COVID. You can see that these patients were more likely to be older, female, have comorbidities including obesity, diabetes, and hypertension, and were more likely to be on 5 aminosalicylates and vedolizumab, which we hypothesize is likely due to the underlying comorbidities of a population that we would not want to systemically immunosuppress. On multivariable analysis, including all of these variables, only older age and obesity were associated with severe disease, and immunosuppression use was not associated with severe disease. So in conclusion, 6 months into the COVID-19 pandemic, this study provided early evidence within a large population of patients with IBD that use of immunosuppression medication is not associated with an increased risk of COVID-19 or development of severe disease, characterized as hospitalization, intubation, or death, as compared to IBD patients not on immunosuppression. Thank you.
Dr. Burke, congratulations on one of the first papers on immunosuppressives and COVID-19 infection. Is one of the first really great papers. Because it was an early paper in the pandemic, you didn't have a lot of COVID positives. Do you think that if you had more COVID positives, the results would have been different, maybe more like the secure database, the secure registry?
Well, potentially. I think the difference between, I think the difference between our study and then the secure registry is really kind of referral bias. So I think that this is a really complementary study to the excellent secure registry, where we looked kind of at a population of patients and had the ability to compare patients on immunosuppression and off without introducing the element of referral. It is possible that it would be more similar otherwise, but I think it's just a different perspective.
You planning any future studies, especially with vaccines, looking at immunity or anything like that?
It's something that was discussed a lot and that we haven't formally pursued. But I think that as we move forward, I think it would be very fruitful, especially as the vaccine data and this virus evolves.
Any questions from the audience? Just send through the Q&A, please.
Kristen, very nice paper. I assume this was the first wave in mass, was it?
It was the very first wave. Yep. This was
Gotcha.
about 6 months. We published this about 6 months after the pandemic began, or submitted it 6 months after the pandemic began.
Have you been able to then capture the kind of the most recent Omicron wave and to see, does that have any difference as we migrate through different phases?
Yeah, we haven't actually started analyzing the COVID data yet, but that's something that I'm very interested in, just because I felt like every day over the month of, December and January, about 15 of my patients were calling me to tell me they had COVID.
What do you tell them? Oh, sorry, go ahead.
Go ahead. Just one other question. In the cohort, so there was 500 or 5,300 or so. So the negative, they were all tested and symptomatic at that time in the first wave, or just not tested?
So the 5,300, or the total population, was just everybody with IBD within our cohort. And so they didn't necessarily need to be tested for COVID. Our sensitivity analysis was restricted only to those that were tested for COVID, looking at positives versus negatives to try to account for any bias in referral for testing.
So in the table, the group called COVID negative, that 5,000 were actually not COVID tested negative.
True.
Just
That's true.
Not tested.
They were not COVID tested.
Not
and at that
symptomatic,
time,
maybe.
there was no such thing as asymptomatic testing. So
Gotcha.
that wasn't really even part of the equation for us.
Gotcha. All right, thanks.
No, thanks. This is a little off topic, but what do you tell your patients in terms of COVID infection when they can get their infusion or injection? How long do you wait?
So I guess it depends on the individual circumstance, but I personally am really not waiting long at all these days. I think as long as somebody is afebrile and really on the up and up from the disease and does not have severe disease, they can get their immunosuppression. I think in the beginning of this pandemic, we were holding it too long for people, and we found that people really started to flare, which was problematic.
Yeah. Do you wait for a negative PCR? Or do you just not retest?
I do not retest anybody. I just tell them they can resume their immune. They're like, oh, I had mild symptoms and I'm getting better. I'm like, go ahead and use your immunosuppression. I think the one kind of caveat, and I get the guidance from one of my colleagues who's doing a lot of the monoclonal antibody trials, is I do wait a solid week after somebody's gotten monoclonal antibodies before giving immunosuppression.
All right. Any other questions? All right, I think we're good. We'll move on to Dr. Cominelli.
Hi, for the best basic science paper we have tonight. Unfortunately, the first author cannot be with us tonight, probably because of the time difference. But we have Dr. Pamanand Sudhakar presenting with the video his paper, which is entitled "Understanding the Molecular Drivers of Disease Heterogeneity in Crohn Disease Using Multi-Omic Data Integration and Network Analysis." And I think the video will be playing in a second. So Sudha, you playing the video?
Yes, I'm sorry about that. Just give me 1 minute and I'm trying to pull it up. Sorry.
Hello, everyone. My name is Padmanand Sudhakar, a postdoc at the IBD Leuven Group. Firstly, on behalf of all the co-authors, we'd like to thank the journal and the editorial board for the recognition of our work. IBD is a highly heterogeneous disease as manifested by the various types of heterogeneity pillars such as disease location, disease behavior, disease subtypes, etc. Disease heterogeneity is very relevant clinically since it also influences disease course, therapeutic response, and major clinical decisions such as the need for surgery. In this study, we aspire to use transcriptomic signatures of blood-derived immune cells along with genetics as a basis to bridge the gap between the phenotypic heterogeneity of IBD and various clinical outcomes. In terms of the data sets used, we profile the gene expression of monocytes and CD4 plus T cells purified from the blood of 33 genotype Crohn's disease patients with endoscopically proven active disease as evidenced by the presence of ulcerations. The genetic mutations were confined to the susceptibility variants as reported by the IBD Genetics Consortium. RNA-seq was used to profile and measure gene expression levels from the two cell types. Various demographic and clinical traits, including those related to disease heterogeneity, such as disease behavior, disease location, etc., were recorded. As for the methods, we used MOFA, which is a latent factor-based model for integrating omic data sets. In our case, these comprise mutational profiles of the susceptibility variants, as well as gene expression profiles from monocytes and CD4 plus T cells. The latent factors can be considered to be equivalent of principal components in a PCA analysis, but rather in this case, it's an advanced version of PCA capturing the variants across the multiple omic data sets. So in a way, one can think of the latent factors as a pan-omics principal component. Once the latent factors are inferred, we can check using regression models how these are in turn associated with our traits of interest. Furthermore, by looking at the variance contributions of the different omic data sets, we can subsequently link particular omic data sets or a combination of them to the traits associated with the corresponding latent factor. Thereafter, by using the weights assigned by the latent factor, we rank the features, which could be genes or genetic loci. This was followed by co-expression network analysis, which aims to infer the relationships among genes based on whether or not they're expressed at similar levels with each other. Subsequently, we independently checked if the co-expression modules, which in other words are tightly connected gene groups, are individually associated with the clinical traits. From a functional perspective, we used a priori information such as signaling in regulator networks to infer clinically relevant pathways and hub genes which could potentially drive the phenotype. You can see from the results of the MOFA analysis that most of the variants captured by the latent factors can be traced back to the gene expression datasets. This can be explained by the fact that gene expression is quite dynamic, and the difference in dimensionality between the gene expression datasets and the mutations is quite large, given that we focused only on the susceptibility variants. Despite the strong variance contributions captured by LF1 and LF2, none of them were associated with any of the clinical traits of interest, as you can see here. On the other hand, LF11 is, for example, not only associated with disease behavior, but also represents the variants from multiple omic layers, namely monocytes and CD4 T cells. Other prominent latent factors include disease location associated LF12, as you can see here, and LF5, which is linked to previous therapies and the number of anti-TNF agents used. So we identified earlier that LFs 12, 11, and 5 are the most relevant latent factors from a clinical perspective. So in this slide, what we have done is we have pulled out the co-expression modules corresponding to the omic layer or the omic layers, which are active within these respective latent factors. Thereafter, we represent in this figure the composition of these modules. So by that, I mean the functions of the genes with respect to their annotations as targets of drugs in Crohn's disease, ulcerative colitis, or other immune diseases such as rheumatoid arthritis. Also, we examine if the genes within the modules are known to be involved in IBD pathogenesis or are coming up as hits from GWAS or equatorial analysis. We then determine the fraction of IBD relevant genes within a particular module and determine the module with the highest percentage of IBD relevant genes. By this approach, examining evidences from different sources, we annotated the phenotypically relevant modules to pre-existing information on disease and therapeutic relevance. As an example, we can see that module 9, corresponding to LF11, which is associated with disease behavior, has the highest fraction of IBD relevant genes. In other words, almost 64% of the module genes are actually annotated as either drug targets or as being involved in IBD pathogenesis. So digging deeper into module 9, which we earlier referred to, we can see that it is enriched with signaling pathways related to interferon gamma and other interleukins such as IL-12 and IL-27. Furthermore, by integrating co-expression networks with protein-protein interactions, we could identify the hubs, which in other words are central hotspots in the network. To further explore the therapeutic relevance of the modules, we examined if the top hubs within the disease behavior associated modules in monocytes are known to be targeted by drugs in clinical trials aimed at developing therapies for IBD or other immune-mediated diseases. We found that phenotypically relevant hubs such as IL-1A, CD40, for example, not only play a role in mediating pathogenesis, but also could be potential targets towards drug repurposing. So in conclusion, we used a sequential workflow to integrate omic datasets to try and understand the heterogeneity of Crohn's disease. Genetics has a low footprint compared to the dynamic gene expression data of the circulating monocytes and CD4 plus T cells. From the downstream analysis using co-expression networks and protein-protein interactions, we identified cell type specific hubs and mechanisms associated with disease heterogeneity, namely disease behavior. In particular, we identified pathways and hubs in monocytes which are associated with disease behavior. That being said, we do acknowledge the need for independent validation in bigger data sets. In addition, more omic layers need to be incorporated from other cell types alongside the inclusion of genome-wide variants without confining to susceptibility loci. I'd like to thank the entire IBD team in Leuven and the supervision and the support of Dr. Bram Verstock and Professor Dr. Severin Vermeer. Thank you very much.
Thank you. So unfortunately, we won't have the ability to ask the first author directly some question, but perhaps I can provide a few comments. It's interesting that this is a paper addressing a very hot area of research now in IBD and other diseases, which is understanding the heterogeneity of disease by analyzing a large amount of data in terms of genomics, transcriptomics, in some situations, obviously, the gut microbiome and other factors. And I remember in the review of this paper, it was uniformly rejected at the beginning, and the major comments from the reviewer was that 99% of people will not understand the data, which I think is partially still true in one way. But I think, it was because of the persistence. Also, one of our associate editor, Dr. Fiocchi, who has been a pioneer in the field of omics, that this paper eventually was accepted in a revised form and actually became the favorite paper from the point of view that won the award. And I think I will invite the attendees also. There is an editorial from Dr. Fiocchi, I think, in the same issue of the journal that explains some of, in a better way, the importance of the paper. But I think, the importance from my point of view is, that by analyzing this large amount of data in terms of gene expression and this module of data that correlate with phenotype, we will better define subtypes of inflammatory bowel disease with the final goal, I guess, to go into what we call precision medicine or precision immunology. So understanding the specific pathway that can be targeted for therapy in individual patient. I think this is the main message of the paper. I think, there are some questions that I would like to ask today. The first author, for example, they analyze systemic cells, T cells and monocytes. But this is always an issue in this type of study in IBD patients. So would you get the same results if you study mucosal cells or lymphocytes and monocytes in the intestinal mucosa, which is obviously much more difficult to do. But obviously these diseases, Crohn disease and ulcerative colitis, are local, specific tissue-specific diseases. Sometimes the systemic circulating cells do not reflect what's going on in the mucosa. And I think 33 patients. I remember some reviewer comments that was done enough in terms of patients. This is a tremendous amount of work, and you can think about it. I think the 33 patients is a good number. Obviously, does not reflect the complete heterogeneity of IBD, but I think statistically is a good number. If you think about most of the single cell RNA paper has been done in the field, has been done on 3 or 4 patients per group. So this is a very solid, in my opinion, number of patients that. And this is what we will have to deal in the future, try to understand this very elaborated bioinformatics, which is one of the big issue in many fields, but in IBD, the ability to understand and to use the bioinformatics, the computational biology will be something. So that's why we were very excited about this paper, which is one of the first to try to integrate this data. And basically, those are my main comments, and happy to answer some questions in the Q&A question that will follow later.
Fabio, just a question for me in terms of advancing this field. I think the comment on overwhelming reviewers with bioinformatics, and how do you ensure that the predictions are valid biologically versus just saying our predictions say all these networks are integrated, but not validating it in a second cohort of samples? Where is the threshold right now, do you think, for publications?
Yeah, I think this is a comment that were raised by one of the reviewers, so that the data needs to be replicated in a second cohort. And as I say, also in this case, also in different cells, mucosal cells and only peripheral cells. So obviously, it's difficult to ask an author that already performed a lot of work to replicate in different cohorts. So my view is that the data is still valid and they need to go out, and this will also serve as good impetus for other people to replicate the data in different cohorts or use multiple cohorts. But it would be difficult to ask someone to say, okay, you have to replicate all the data in a second cohort, because this is a tremendous amount of work and also very expensive type of work now to do all the gene expression, the genomics, and so on. So I think we felt, for example, for this paper was more important to publish the paper, put the data out, and then stimulate other people, even if the story is not complete at this point. But there's a lot of work needs to be done with this from many people to obviously validate the data. Thanks. That was a very, very excellent question. Okay, I think we can go to the next paper that Alan, you will introduce, right?
Yes. Great. So thank you, Fabio and Sonia, for the Best of IBD journal. The next session is, or half of this is to look at Best of CC360. And 2 papers were selected from the papers published this year in CC360. And I'm delighted to have live authors for both of them. So the first paper is from a combination of different groups collaborating to look at the association between serum Ustekinumab levels and a measure of mucosal healing in patients with IBD. I'm delighted to welcome Dr. Robert Batat this evening, who's going to present this on behalf of the collaboration. And he is from the IBD Center at Cornell in New York. And he's going to present their data on Ustekinumab and associated endoscopic remission in patients with IBD. So Dr. Batat, it's floor is yours.
Everyone hear me? Great.
Yes.
Thanks for inviting me tonight. I'm presenting this on behalf of a really strong work done by Margaret Walsh and Mark Silverberg, who primarily drove this. This study is on serum Ustekinumab concentrations and how they're associated with a novel biomarker panel called the endoscopic healing index. So just as some background, we know Ustekinumab is effective for induction and maintenance of remission in Crohn's disease. It's an interleukin 12/23 antagonist. And there's been some differing data on Ustekinumab drug concentrations and outcomes depending on which assay primarily was studied. And so the first data that came out looked at the homogeneous mobility shift assay, and all that to say is that it's a drug tolerant assay that is able to detect both drug and antibodies. And that group, which I was involved with from Montreal, was found a cutoff of 4.5 was associated with endoscopic and calprotectin outcomes in a observational cohort, and then post hoc data from the Unity trials using Janssen's proprietary assay, which is not used in clinical practice, found and uses a CLIA assay, had found that there were levels of 0.8 to 1.2 that were associated with outcomes from the trial. So separately, there's been work recently on the endoscopic healing index, which is a blood test that measures 13 proteins and then generates a score from 0 to 100 based on the quantification of those proteins that are inputted into an algorithm. 0 is no inflammation whatsoever, and 100 is significant inflammation. And it's been studied and published. And what we had previously found was using that it performed quite well. And similarly to other non-invasive biomarkers, an EHI cutoff of greater than 50 was quite specific to confirm inflammation. An EHI below 20 was sensitive to exclude endoscopic inflammation. And so with that background, we know that this test performs well to detect, to either rule out or rule in endoscopic inflammation based on the cutoff. And so with that background, in a commercial laboratory database from Prometheus, we had looked at adults with Crohn's disease who had both Ustekinumab and a concentration measured and EHI test done within 30 days of each other as standard of care. And then the analyses based on those previous data looked at differences in Ustekinumab concentrations between those with remission defined by EHI, meaning an EHI less than 20, or active disease defined by EHI, so an EHI of 50 or greater. And then similarly, because there's not only less than 20 or greater than 50, but there are buckets. So less than 20, 20 to 50, and 50, the Ustekinumab concentrations were compared as well between those groups. Then importantly for clinical practice, we did an area under the curve analysis to find a specific Ustekinumab concentration that could differentiate remission from active disease. And below and above that specific threshold, we compared patients with remission or active disease. So there were 337 patients. Most were receiving every 8 weeks ustekinumab. The median concentration was 5. The median EHI concentration was or value was 37. Just looking in panel A, you see that as you go up ustekinumab concentration quartiles, you have higher proportions of patients with EHI defined remission. And similarly in panel B, you see that as you go up ustekinumab concentrations, you get lower proportions with EHI active disease. So higher concentrations of ustekinumab, less patients with active disease, and more patients in remission. Just put in a different way, we had found that the EHI concentration, as you go up ustekinumab concentration quartiles, and the EHI value trends down. We also just compared between those 3 buckets of patients, so less than 20, 20 to 50, and greater than 50, and we find that the concentration in those in remission with less than 20 was 7.5 as compared to 5.2 with those 20 to 50 and 3.1 greater 50 or greater. And so you see that higher ustekinumab concentrations, more patients with favorable EHI values. So then doing the area under the curve analysis, the value that was found using the Prometheus assay was 3.75 micrograms per ml. And that was specific to differentiate remission from active disease. Clearly, the sensitivity was not excellent. And then you see that the curve was significant, though. And so put in a different way, ustekinumab concentration greater than 3.75, there were higher proportions of patients in remission compared to those with lower concentrations. Or on the right-hand panel B, you see that if you have a ustekinumab concentration of greater than 3.75, very few patients had active disease defined by EHI as compared to lower ustekinumab concentrations. Antibodies didn't play a major role, so we see that various antibody concentrations here, but what seemed to really drive the EHI values was the drug concentration of ustekinumab. So we see that these 2 patients with antibodies who had low drug concentrations, they had elevated EHIs, whereas the 3rd patient with antibodies, although they had detectable antibodies, the ustekinumab concentrations were high, 9.2, and the EHI was very, very low. So in conclusion, the ustekinumab, there was an exposure-response relationship between ustekinumab and the EHI-defined remission in active disease. Using this homogeneous mobility shift assay, the same assay that was used in that previous CJH study, we found that it was a similar value, 3.75, 4.5, in the same ballpark in terms of a cutoff for defining outcomes. We also see that the EHI had relationships with drug concentration. So it validates the EHI, it validates ustekinumab concentration. They kind of cross-validate each other. And then clearly, like any database-derived data, there are limitations because we don't have significant data on patient characteristics or dosing or additional medications or whatnot. So I'd like to thank everyone for having me present this. I think it's an interesting topic, and I'd be glad to take any questions.
Dr. Padat, would 3.75 be your cutoff? Because 82% of your patients were on every 8 weeks, and it seems like many of my patients are on every 4, every 6 weeks. I mean, and it's so hard to get those intervals, through insurance. It's such a pain. So is that what you're using?
I use particularly, given the current insurance milieu, where I think we have had a lot of patients on Q4 now being rejected for that and being put on to Q8. So I'm actually using 4.5 because I think there's data to support that for endoscopy as opposed to a biomarker. And you're going to have more patients below 4.5. So it allows a more broader group of patients to be dose escalated to Q4. And I think we all feel that many patients need to be on higher doses than Q8.
Yeah, and insurance has been really bad this past year in terms of approving
Yes.
higher doses.
And in
Yeah,
fact, they're asking now for drug levels, I find, to justify dose escalation, which we could, argue about, but I definitely think that, it's been problematic.
yeah.
Robert, thanks so much. So just to clarify, the EHI assay and the drug trough level assay, they're both already commercially available. Is that correct? Or the version that are available now for patients to use? Okay.
Yes. And we, and I order it routinely through Epic.
Great. And so then a bigger question is, these association studies often trigger people to start altering doses to get drug levels higher, even if the patient's in clinical remission. So do you find there's enough data for Ustekinumab currently to advocate driving your dosing towards these levels, even if the patient's already in clinical remission?
Well, with Crohn's disease, I really do base it on the endoscopy as opposed to clinical symptoms, just because there's such a discordance between clinical symptoms and endoscopic findings. So often if I have a patient, and we've all seen the patient who has, an SCSCD of 30, and yet they look great, but something bad is going to happen to them. They're going to obstruct or whatnot. And so I typically will, do this in conjunction with some form of objective marker. And if I see that endoscopy is very bad, it depends how low, the drug level is to guide my next step. So if I have a drug level that's near undetectable, and the scope is very bad, I may try to IV reinduce and then try Q4-week dosing. And there are some data to support that. If I'm approaching a threshold and the value is say 4.4 and the SCSCD is, 33, there in that case, I probably, the utility of dose escalating that patient versus trying an alternate, what is the incremental benefit to get you over, from 4.4 to 4.6, there, I think there's probably less of a gain there.
Great, very nice. Thank you. Any other questions from the panel before we move on? Great. Well, listen, thank you. That summary, very helpful, very practical for our clinicians in use. There is one question actually that before we move on is your experience with other commercially available assays. So not the Prometheus one, other assays like LabCorp. How do we use their levels when we're comparing to these papers that are using Prometheus? Is there good data to show their correlation?
Yeah, so it depends. It's a great question because we will often, people will often transpose the data from this assay to another assay, and you actually can't. And so there are some data. There's a study by Verdun et al., a group from Montreal that had actually looked at compared Ustekinumab concentrations for LabCorp to this homogeneous mobility shift assay, and one more assay as well. I forget the third one, but there are data out there comparing assays for Ustekinumab, Infliximab, as well as adalimumab across different platforms. And so I don't, have it all memorized, but I do often just use those references to convert them when I need to. But I do think that it's important when you're doing your own, when they're coming from a different practice, it's important to take that into account. But when you're within your own practice, it's important to just use the same assay all the time. Whichever one you use, stick to that.
Great, lovely, thank you. So we're going to move on to our next paper. Thank you so much. So our next paper is from Dr. Nabil Khan, who's going to present on behalf of the group at the VA and the GIs and School of Medicine in Pennsylvania. And they're going to present their paper on efficacy and safety of single and double switch biosimilars amongst patients with inflammatory bowel disease. So Dr. Khan, the floor is yours.
Thank you very much. First of all, I'd like to thank the CCFA for this award and for giving us the opportunity on the behalf of all my co-investigators to share that data. and to talk a little bit about the VA database and all the things that we can do with it. So a topic today is the efficacy and safety of switching from Originator Infliximab to single or double switch biosimilar among a nationwide cohort of IBD patients followed in the VA healthcare system. So the advent of Infliximab approximately more than 2 decades ago actually revolutionized the management of IBD. Despite its efficacy, however, there are certain barriers to the adoption of widespread use, with cost being the most prominent amongst them. Many different healthcare systems have an algorithm that they use for approving, as well as in many countries where there is a nationalized healthcare system, the access to anti-TNFs was limited. To overcome these financial constraints, biosimilars were developed and they were approved for use, and now they have been around for quite a few years. As a result, patients were switched from the originator to the biosimilar. And among these switches, the VA was actually at the forefront of it, as all patients who were on either the Infliximab or the original biosimilar, their physicians were asked to evaluate whether they were appropriate candidates to shift onto SP2 or Inflixis, and if they were, a shift was advocated in order primarily for cost-saving purposes. So this gave the VA a very ideal place in which to conduct such a study, because a significant patients were shifted from the originator to from the Cephas biosimilar shift to the SP2, and that allowed us to do the study. And this met the gap of the limited data among IBD patients who were and to evaluate the safety as well as the efficacy of a single switch versus a double switch. So our aim was to evaluate the efficacy of switching to Renflexis or SP2 from originator Infliximab, which would be a single switch, or from originator Infliximab to Inflectra and then to SP2. So there were actually 2 different groups, one of which shifted directly from Infliximab to SP2, and the other went from Infliximab to SCTP13 and then to SP2. And I think with more biosimilars are getting introduced, there will be more of those switches taking place. So we conducted a retrospective study among the US national VA healthcare system. The patients were those who were followed in the VAHS with a diagnosis of IBD based upon an algorithm that we have validated with the positive predictive value of approximately 94%. We have done about 40-50 studies with this cohort, and it has been pretty rigorous validation with individual chart reviews that took place. Patients had to have a CPT code for Infliximab before starting SP2. They were switched to SP2 following at least 3 months of stable IBD. And the reason for that is that we wanted to ensure that the patients, when the switch was made, they were actually stable and they were not having a disease flare or increased disease activity. And for this particular study, our definition of stable IBD was not requiring oral or intravenous steroids due to, for IBD reasons, not being hospitalized for disease flare. And there was no change in the dosage or frequency of the drug for the management of IBD. There were 2 variables that we looked at. One was the single switch, which I mentioned initially from Infliximab to SP2, and the double switch, Infliximab to CTP13 and then to SP2. Our primary outcome was a composite outcome looking at SP2 drug discontinuation and or not being in remission after 1 year. So if somebody stopped the drug or they were not in remission, and our definition of not being in remission was the same as that of being in a stable disease, that is that they required steroids for the management of their disease, they were hospitalized or underwent a surgery for the management of their disease, or there was a dose escalation, or there was a decrease in the time interval for the medications in the following year after the switch was made. The secondary outcome was the reason the patient were not in remission or why they stopped the drug, which is more of a descriptive outcome, which we have outlined later. So our cohort was actually quite significant, quite a large one. It overall comprised of 271 patients. there were about 101 patients who had a single switch and about 170 who had a double switch. This was one of the larger cohorts in which a double switch took place. If you look at the patient characteristics, they were actually pretty similar as to be expected from a VA study. They were predominantly male as well as Caucasian. So there were a higher percentage of Caucasian patients in the single switch versus the double switch, as well as the BMI was a little higher in the single switch versus the double switch. But otherwise, they were pretty well matched based upon all the covariates that we looked at, which included age, gender, race, IBD subtype, BMI, disease duration, baseline Charlson's comorbidity at the time of the switch, smoking status, concomitant use of 5-ASA, or whether they were on a concomitant therapy with either azathioprine or methotrexate, which were grouped together. So if you looked at the primary outcome, at the end of 1 year of the whole cohort, approximately 74% were still on the drug and had stable disease, while 26% had either stopped the drug or had a disease flare. Within the single switch, the number, as well as the double switch, the numbers were pretty similar. They were like 25% in the single switch and 27% in the double switch, and they were not statistically significant. So the groups were pretty well matched, and then the outcomes were pretty similar also. Now, if we did an initial evaluation of all the individual covariates, and then depending upon whether they were significant in the univariate analysis, they were put in a combined analysis, and only two factors were really found to be significant. One was a little bit of a surprising element that we found that African Americans who switched had a much higher probability of either stopping the drug or having a disease flare within the following year. And secondarily, disease duration, the longer the disease duration, the lower were the chances that they would carry off the drug or have a flare within the following year. But between the two different groups, there was actually no statistical difference whether there was a single switch versus a double switch. There was no statistical difference between the two groups in terms of continuation of drug at the end of 1 year, as well as remaining disease flare-free. Now, we looked at the reasons why they were stopped the drug, or why the dose increase took place, so they had steroid utilization or hospitalization. The primary reason for stopping was a loss of response, and that was similarly seen in both the single switch as well as the double switch. Hypersensitivity reactions were relatively low, about 2% in the single switch versus 3.5% in the double switch. So that kind of put a little bit of ease that by this multiple switches, there was not an increase in hypersensitivity reaction. Dose increases as well as steroid utilization and hospitalization was roughly similar between the two groups. So if we looked at the reasons for discontinuation or the factor of the reasons why they've continued the drug but still were not on stable disease, they were pretty similar between the two groups. So in conclusion, among IBD patients in remission, double switch was equally effective as compared to a single switch. Hopefully, the study will potentially aid in reassuring gastroenterologists who have concerns regarding the safety and efficacy of switching between multiple biosimilars for treating IBD, with the primary aim obviously being cost saving that are associated with the switch that takes place. Well, I want to thank my co-investigators as well as the foundation for allowing us to share this data as well as for accepting our paper. Thank you very much.
Thank you very much, Dr. Khan. That was a very nice summary. So I'll start the ball rolling with a question. So were these, were the patients participants in the switch, unaware of the switch, or was it just made at the pharmacy infusion center level?
No, the patients were familiar with the switch, so that it was not at the pharmacy level. The physician had to personally order the switch in order for it to take place. So all physicians were given a guideline by the VA, for example, like within my VA also, and I was also given a guideline that you can evaluate your patients, and we were provided a list of the patients who were on Infliximab, and then to evaluate if we felt that those patients could be switched on from either the first original Infliximab or from Inflectra onto Renflexes. And the primary, obviously, goal was that they had a much better contract with Renflexes that would lead to a large degree of money saving. In fact, just within my own center, they saved enough money to pay for 3 times my salary. So, I mean, there was a major financial incentive in switching. And this was also our aim was to look at whether the financial incentive was just there or was there any associated patient detriment that took place with it. And as expected, we did not find any patient detriments associated with it.
Oh, so just to be clear, so were the patients informed that and get permission to switch, or just switched either way?
No, the patients had to, I mean, when I talked with my patients on that, we had to talk with the patient and they had to agree to the switch.
Great.
It's
okay.
Still a free country. I mean, you can't switch people right off.
Well, I guess in theory, at a formulary level, some of these decisions are made regardless, you know. And then, so did you experience the nocebo effect where people have this concern about switching and experiencing loss of response because of nocebo effect versus true loss of response?
Not really, actually. So within our discussions within the patient groups, they really were not that concerned about the switch. And that is generally seen within the VA population per se, that they do not have, so that is a different kind of a population from the general practice population, that they have generally whatever you tell them to do, they do that, and they do not have that much of a concern with it. So most of our discussions, and now obviously I cannot be saying that, but this is what happened in all over the VA, that what was the degree of discussion that took place between the physician and the patient before the switch was made. But generally the patient were not that concerned about the switch.
Great.
But the good factor about this is that this is a nationwide study looking at 150 different centers. So even variation between 1 or 2 centers is not going to impact the results that much. So this is the good part of the VA, is that you have 150 centers all over the nation contributing to data.
Lovely, lovely. Sonia, do you have any comments or questions on this?
You mentioned an effect about race with Black patients. Could you just repeat that and just tell us what you think about it?
So Black patients had a higher likelihood of either getting off, so stopping the treatment, or having a flare within the following year. Now, Black patients do have an increased rate of perianal disease as well as having more penetrating disease. There are some genetic factors that are involved also. So the number was obviously small also. So there was predominantly, there were about 27 or so, I think there were about like 10% or so Black patients in this whole group. So I don't know if this is a finding that is provocative, which perhaps needs a little bit more follow-up within a larger cohort of African-American patients to see if it holds up or not. But with this small sample size of 10% of the total cohort, this was a finding that we found a little surprising, but there is some pathophysiological as well as some genetic maybe contributor factor to it.
Great, thank you so much. So we're getting close to the end of the session. I'd like to thank all the authors who've joined us live and who recorded for us to contribute. I'd like to hand it back to, is it Sudha to wrap up or Orna to wrap up?
Yeah, I'll do a quick thank you to all of our editors and authors for joining, and congratulations again on your well-deserved awards. And I'll just pass it to Sudha for some additional information about upcoming programs. Thank you, everybody.
Thank you. If you're interested in receiving more information about the IBD Journal or CC360, you can go to our website, crohnscolitisfoundation.org, under membership. As a member, you receive the monthly IBD Journal as well as quarterly emails about Crohn's and Colitis 360. We also have monthly webinars such as these each month. So next month's topic will be on pediatric health maintenance, presented by our advanced practice providers of our nurse and advanced practice committee. Finally, I'll be emailing out a post-eval for this webinar. So if you attended and would like to provide additional feedback, we would greatly appreciate that. So thank you again for attending, and have a great night.
Thank you.